Good afternoon, everyone, and welcome to the Black Health Trust weekly program. My name is Michelle, and I'm your host here to introduce and assist with today's program. Our topic of discussion today is Black infant mortality, saving our babies. We are so pleased you've chosen to empower yourselves today by joining us. As always, Black Health Trust is grateful to have its regular and faithful attendees back and those new to the program, so thank you for being here. I'm proud to say for the first time that I hope you enjoyed celebrating Juneteenth as our official federal holiday recognized by our government. It was the right call. Now let's continue to keep up the good trouble. I'm also thankful to be here amidst COVID and everything to say Happy Father's Day to all our dads, uncles, mentors, and father figures out there. You are so appreciated. So today, the panel will be moderated by the distinguished Dr. Randall Maxey, Chief Medical Officer of Advanced Community Medical Care Corporation in Los Angeles and President and founder of the Black Health Trust. Dr. Maxey will introduce his distinguished co-moderators, Dr. Barbara Neighbert-Stevens and Dr. Ivan Walks, who will then introduce our guest panelists today. Black Health Trust was founded in response to the COVID-19 global pandemic and Dr. Maxey's personal and urgent desire to keep his own family safe. Fortunately for us, his commitment to researching and informing his tribe about how to stay safe and healthy during the pandemic evolved into a much larger vision for the community you see today in the Black Health Trust program. So the purpose and mission of the Black Health Trust is to provide credible insights from our community of health experts to best serve our communities of color with a coalition of leading and longstanding Black medical professionals across a diverse spectrum of disciplines, and to offer their expertise and insights into our physical and mental health during these challenging times. These opinions are offered to help educate and inspire you to take your health seriously and to ask questions of your own medical practitioner. That said, I'll read our weekly disclaimer, which is also located in the chat box if you need to refer to it. Please note that the information communicated on this program is not intended or deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice and direction pertaining to your particular situation and needs. The information presented here is not advice, but rather opinions and recommendations from credible sources. Black Health Trust, its representatives, members, employees, attendees, heirs, assigns, and guest speakers and presenters presume or assume no liability whatsoever in connection with the information presented or used by anyone, nor are these discussions directed to specific situations. Again, we strongly encourage all attendees of the program to consult their own legal or medical professionals for conclusive guidance on how to proceed in your own personal circumstances. Now I'll share a few housekeeping items for the program. This program is a live event and is being recorded on different public platforms like YouTube and Facebook Live. By your voluntary attendance here, you understand that if you choose to participate and prefer not to have your image and likeness displayed, there are audio and visual settings on your own personal device that you can use to control and block your picture or mute your voice throughout the program. That said, all participants should remain muted throughout the program until you're asked to contribute. With regards to the chat room, if you have questions, and we certainly hope you do, you can enter them in the chat room. Please limit your questions to 2 questions per topic being addressed as our time is limited, and please do not use this forum to advertise or promote your products. So we are still in this together. If this program is and has been valuable and interesting to you, please visit the website to learn more about our programming and how you can support BHT so we can continue bringing our community outstanding content. Visit blackhealthtrust.org. That's blackhealthtrust.org. So now on to the thank yous. We thank the Black Health Trust Steering Committee, the Executive Board, our amazing administrative assistant, our media director, production and Zoom technician, BHT sponsors and supporters, and all the people behind the scenes for their time and efforts to make this programming possible. We also thank our wonderful, wonderful distinguished physicians and special guests. We thank you for sharing your valuable time, your information, your educated insights. Your participation and support help to continue to empower our communities of color. And this is critical to our present and future well-being as a people. Black is beautiful, as we all know, and knowledge is power. Welcome again, everyone, to the Black Health Trust Weekly Program. This is our community, and this is our time to take care of our health. Grab your tea, coffee, get comfortable, and lean in. And Dr. Maxey, you know what to do. Please join us by honoring us by beginning today's program.
Thank you so much, Michelle. We appreciate you. And I appreciate my 2 co-moderators, Dr. Barbara Neighbor-Stevens and Dr. Ivan Walks. And this is an extremely important, timely subject, and we want to get right to it. Dr. Barbara Neighbor-Stevens, and would you introduce quickly Dr. Walks and yourself, and let's go to our speakers.
Thank you so much, Dr. Maxey, and good afternoon, everyone. It's wonderful to have another opportunity to be with you and to share some important information from very credible sources. But first, let me introduce my co-moderator, Dr. Ivan Walks. Dr. Ivan Walks, for those of you who join us every week, know he is a very established and experienced psychiatrist, but also a public servant, having spent several years in the role as Chief Medical Officer for the District of Columbia, as well as providing advice to our national leaders and helping to set public health policy. He has his firm that is involved in psychiatric practice and has been such an addition to the Black Health Trust group. He is the one that manages to keep us all on an even keel.
That's why we're in trouble. Please move on to the important people.
And with that, let me quickly move on to our first speaker. Our speakers today are sharing insight and expertise around the travesty that is occurring in this country around Black infant mortality. Our first speaker is a maternal fetal medicine specialist, and I especially wanted him to join us today because his role is to get the mother through a pregnancy so that the child is delivered. But there are, as you're going to learn, there are a lot of things that can impact that journey. And Dr. Haywood Brown is going to share some of those insights with us. Dr. Brown has spent many years in clinical practice as well as in academic roles, having been chair at Duke and now serving as Senior Vice President of Academic and Faculty Affairs at University of South Florida here in Tampa. Dr. Brown also is a past chair of the American College of OBGYN and used that position to help advance the cause of Black maternal health and mortality. So you will see very shortly that he is certainly an expert guide through the preconceptual and pregnancy phases of early childhood. Dr. Brown?
I think there may have been an issue with Dr. Brown's connectivity. I would fill in right now and let's give him a moment.
Dr. Neighbor-Stevens, why is this topic so important to us?
This topic is so important to us because we lead the world in the developed world in infant mortality. And in the United States, and I'm not going to steal the thunder from some of our speakers, but I will say that our babies die at twice the rate of white babies in this country. I see that Dr. Brown is back.
I'm sorry, I lost my internet as particularly, so I'm trying to figure out how to get it back, but I'm on my phone, so we should be in good shape. Can you hear me?
We can
Yes.
hear you.
Okay, great.
You're on.
Sorry about that.
No worries. Glad to have you back.
Go forward with your presentation, Doctor.
Okay. Well, thank you all very much for having me to present this important topic. And you have control of my slides. As Barbara has said, I'm Haywood Brown. I'm a professor of obstetrics and gynecology here at the University of South Florida. And one of my initiatives, of course, for a number of years has been Black infant mortality and maternal mortality. I served 20 years as the evaluator for the Indianapolis Healthy Start program, which is geared toward Black infant mortality. Next slide. So this is a slide of Dr. Ezra Davison. Dr. Davison was president of the American College of OB/GYN in 1990. Many of you may know his name. He was a tremendous leader. And he basically was the person who started the Fetal and Infant Mortality Review Program. And I was fortunate enough to be the second Black president of ACOG in 2017. And Dr. Ezra Davison actually was one of my escorts. And of course, he unfortunately died the year right after that. And I was scheduled to give a talk for him in his honor at the National Healthy Start program. And he died several weeks actually before that event occurred. So he is dearly missed and really set the groundwork for fetal and infant mortality review. Next slide. So this is basically just the infant mortality wealthy countries map. And again, I'm on my phone, so I can't see these very well. But as you can see, we are really not doing very well here in the United States when we talk about infant mortality, whether we talk about being 21st or 31st or 25th, it really doesn't matter. The reality is there's so many other countries that are doing so much better than we are. And again, we are one of the wealthiest countries in the world, and it's really a travesty. Next slide. So why is preconception care so important for women and also interconception care? Well, we know that first of all, pregnancy spacing does decrease the risk of prematurity. It also improves pregnancy outcome. And so one of the things that we know is that infant mortality, particularly for Black women, is related to preterm birth primarily. Some of the leading causes of infant mortality, of course, number one is congenital anomalies. And that is related to a number of different things, including diabetes and so forth and so on, and birth defects. But chronic medical conditions as well lead to preterm birth, such as preeclampsia and all those type of things. And of course, low birth weight is a generational thing that we must deal with regard to small for gestational age infants. As you all know, 50% of pregnancies are unplanned in the United States, and maybe more so than we realize. And of course, unplanned pregnancy also is associated with more adverse pregnancy outcome. And of course, we also recognize the fact that poor reproductive health leads to generational reproductive health issues, and all women and men should develop a reproductive life plan. And I include men particularly because I'm going to talk about some data today on fathers and the importance of fathers in this whole cascade of prematurity and infant death. Next slide. So one of the things that we know about preconception care is it is an intervention aimed at identifying and modifying behaviors. And so the reality, whether you're smoking or whether you have, whether you're anemic or whether you're whatever, many of these type of things increase the risk for adverse pregnancy outcome. And so emphasizing the factors that can be added upon prior to conception in early pregnancy, such as this simple thing as taking a vitamin with a prenatal vitamin. And again, this has been the law of the land since about 1990s. We recognize that folic acid was associated with decreased risk of neurotube defects. But the data is even more profound than that, because when you think about folic acid and its contribution to lower risk for low birth weight and prematurity, that data is also pretty clear. And so preconception vitamins is very important. And I talk about this all the time with my infertility patients that I see in preconception consult, because they're trying to have a baby at some of the challenging stages of their life, many of them with polycystic ovary disease syndrome and insulin resistance, and having a folic acid is very important to their overall health and well-being. Next slide. So this just shows you a little bit about what has happened over the last 100 years almost since we've been keeping data. And you can see I show both of these slides because one relates to infant mortality and the other relates to maternal mortality. And I would say that, the product of being the product of the 50s, the early 50s myself, You know, I was the first child of my mother's to be actually born in a hospital, and the rest of people the children were born at home. But the infant mortality rate in the 50s was significant. And of course, there are a lot of things that changed with regard to dropping the infant mortality rate, particularly in Black communities, including many programs that are out there. But what we've seen is that we still have significant disparity in maternal and in infant mortality, and a number of factors related to that we'll talk about today. Next slide. So this kind of shows you a little bit of the differential between Black and infant mortality and white infant mortality over the courses of years. And you can begin to see again, Black infant deaths have always outpaced white infant deaths for a number of different reasons. And you can see where we are in the third to the last bar, the next to the last bar there. And of course, the second highest rate of infant mortality in this United States, of course, is in Native Americans. And we were talking earlier today about the importance of Native American health and so forth, and helping individuals who live in those areas. And this is a very important aspect for us to keep in mind as well. And some of the programs that are geared toward Native Americans is very important to their well-being. Next slide. So this is about racial disparity in infant mortality. And again, what you can see here is that we see what has happened over the years, but you can again look at the lines there and see where the differences in Black and white infant mortality and Native American infant mortality. And I know that some of my colleagues are going to talk about some other aspect of this in just a little bit, but this is extremely important for us to keep in mind that this disparity still exists. And many of the factors related to prematurity really are related to stress. And so I wrote a paper for the National Medical Association was published in January, that talked about generational stress. And we're talking about Juneteenth and coming out of slavery. In reality, believe it or not, pregnant women received the best care of any of the slaves on the plantation because they were part of the wealth of the slave owner. I mean, they really didn't care that much about the children that were being born as much as they did about keeping the mother healthy and keeping her able to get another pregnancy and so forth and so on. So the reality is at the end of slavery, going into particularly the rural South, women were still trying to be as healthy as they could be in cases of poverty and so forth and so on. But they had a nuclear family that really helped them to gain many of the health advantages that they got as best they could. But keep in mind that low birth weight and prematurity and infant mortality were certainly significant then. And of course, they continue to be much more profound today than they need to be. Next slide. So this basically tells you a story here of looking at where infant mortality is today. And notice that the rural South still has a significantly higher infant mortality than many of other states. And I want to also remind you, as we talk about extension of Medicaid and expansion of Medicaid and so forth and so on, where have we not done this? We've not done this in most of the rural South. And these are the old Confederate states of the United States. And of course, the reality is, just as they fought against having Medicare in 1965 because it was tied to integration of hospitals, they also fought having Medicaid. And of course, expansion of Medicaid became a real bad term on Capitol Hill when I was there. But even though we're seeing some states now, including Florida, who are willing to extend Medicaid because it's associated with so much money coming down the pipe. Next slide. Now, this is an interesting slide, and I pulled this years ago, and it says if Alabama were a country, its infant mortality rate of 8.7 per deaths per thousand would place it between Lebanon in the world rankings. Just think about that. Just think about that. And so we're talking about a Middle Eastern country. We could compare it to a number of different places as well, but this is not this is a factor that we need to keep in mind, particularly when we talk about just overall infant mortality in the southern states. But when we talk about the disparity in Black infant mortality in these communities is even quite more profound. Next slide. So this is another slide that I like to show, and that really is the income gap in infant mortality. Now look at this. What it tells you is that poverty is a factor. And when you tie poverty to racism and poor health care and quality of care, these are all factors that play a role in this disparity. And so the gap of income and how it has changed the whole landscape of Black infant mortality, you can see here. And so even though we talk about infant mortality crossing all economic gaps, and there are a number of reasons for that. And again, because I talk about stress as a factor, and whether you have Blue Cross or Blue Shield, or you have Medicaid, you have no insurance, Black women certainly have more stress during their pregnancies, whether they're lawyers or whether they are working in healthcare or whether they're working at the front desk or something. I mean, the factors are very real with regard to those types of things that we know play a role in health outcomes. Next slide. So these are some specific hypotheses on stress and prematurity. And I really won't go through this except to say, we know that and I have a lot of colleagues on the phone who can here who can appreciate this, stress is associated with inflammatory cytokines. And inflammatory cytokines are really one of the factors related to preterm birth. And so, as you know, when we get stressed, our cortisol levels go up, our blood pressure goes up, our pulse rate goes up. And of course, if you don't have time to kind of unwind from those type of things, you know, as we know, stress leads to heart disease, and the uterus is just another smooth muscle and responds to those pro-inflammatory cytokines just like that. And so the reality is perceived stress, or how we respond to our stress, is very important in terms of someone sent me an email this morning, and it was really related to something at work. And I said to them, I plan to have a stress-free day today. So I really don't know why you're sending this to me at 7 o'clock this morning. I mean, on Father's Day, no doubt. And I said, we're not going to deal with this. We're going to deal with this on Monday. So the reality is that that stress is a factor and that plays a role in African Americans and their response to pro-inflammatory responses. And so you think about pouring racism into that as well, which also increases your stress rate. African American women are at higher risk of preterm birth as a result of their relationship between their stress and the pro-inflammatory cytokines that they enact with regard to that. Next slide. So this is the prematurity report card. And this is something that the March of Dimes does every year again. And you look at the dark red, these are people with the F report cards. You can also see the D's and the C's on that report card. And what do you see again? You begin to see the South, the same group of individuals who came out of slavery, who really were part of the sharecropping system, a part of the current mentality of being oppressed from a voter registration and so forth and so on, that are factors there with prematurity rates. Prematurity rates, leading cause for Black infant mortality. Next slide. So factors accounting for the prematurity differences in low birth weight, low risk whites and Blacks is the current health status, and talk about the childhood and adolescent health history as well, which play a role. I've already mentioned stressors, nutrition. We know nutrition is a factor, anemia in Black children. I don't need to tell many of the pediatricians on the phone that, because I grew up anemic myself, even though I didn't really know I was until I realized when I got my college physical, oh, you're anemic. I said, I thought I had been eating pretty good, but evidently I was not eating and taking vitamins and doing the things we needed to do. And quality of medical care, as we've already talked about those things. If you're greeted with, I call it evil intent at the front desk when you're going in for your prenatal visit and someone's stressing you out because you're there, it certainly does not improve your chances of having a good pregnancy outcome and a better health outcome. Next slide. Next slide. So I want to spend some time here in my last part of this today really talking about father's involvement. And I've done some work on this myself. I used to teach what we call a new fathers boot camp in the prenatal clinics, which really was more about trying to help the father bond with the pregnancy, father, develop their own personal awareness. And I did a survey looking at, how much did patients know about, how much did fathers know about pregnancy? How did they define preterm birth? Had they ever heard of postpartum depression? Simple things like that. And I did it across educational levels. And believe it or not, the graduate males had a tendency to calculate 9 months rather than 280 days. And so they always assume that pregnancy was really less than 40 weeks. So paternal involvement during the perinatal period decreases the portion of infants born who are very low birth rate or preterm. And I'm going to show you some data that reflects that, not to get too hard on the data, but here you go. Next slide. So this is what it looks like in a study that was done by Leo and published in the journal Maternal Child Health, actually in 2010. And basically what you can see is that the relative risk of low birth rate, if the father was present in the home or the father was absent in the home, you can look at what happens if the father was absent. The relative risk of increase for low birth rate and very low birth rate and overall prematurity and very preterm was significantly higher. Now, we know that part of that is just relationships and having support. There's support and there's not support. It's one thing about being present and being supportive and decreasing stress. And this is basically what this is all about when you begin to kind of show this data. Next slide. So this is another a factor, and we asked this question when we did our survey. The father's attitude toward breastfeeding. We know how important breastfeeding is overall, and there are many programs now geared toward improving breastfeeding rates in African American women, which have one of the lowest, some of the lowest breastfeeding rates. But we've done a very good job of those type of things. 75% of women make decisions about breastfeeding before pregnancy or in the first trimester. And 40 to 75% of women in this survey reported that the perception of their partner's opinion really helped them to drive their decision around breastfeeding. And so it really is part of the prenatal education when the partner's there to talk about the risk benefits of breastfeeding for their infant. And we know that there are many benefits for the mother, but clearly the benefits for a baby. And what we were able to demonstrate, even in our Healthy Start data in Indianapolis, that our adolescent women were more likely to breastfeed than the national average because we taught them about the overall benefits of breastfeeding, including less childhood illnesses and so forth and so on. And not to mention the fact that it was certainly much more beneficial and more cost effective to breastfeed. So even breastfeeding for 4 months actually decreases the risk for long-term adult cardiovascular disease in women and in their offspring. Next slide. So these are some of the lessons learned from our fetal and infant mortality review from the Indianapolis Healthy Start, and that is pre-existing maternal and infant conditions, poverty and prematurity were common themes in our case review of infant mortality, and pre-existing medical conditions and compliance with treatment, for instance, for diabetes and hypertension was also a factor. And motivating women and improving their mental health and dealing with substance and social issues was certainly a factor as well that decreased the chances of them having another infant death. Next slide. Next slide. Now, this is an area of my area of work, and that really relates to preterm premature rupture membranes. which is really when it occurs at 20 weeks, 21 weeks, and 22 weeks, where it really is the biggest contributor to extreme low birth rate. And what I want you to do is pay attention to what the recurrence risk is. If you look at women who have preterm premature rupture membranes, at less than 32 to 34 weeks, the risk of having it happen again is significant. And we know that this is where interconception care plays a role. And whether you're a big believer of progesterone or not, the reality is that for Black women, one of my biggest concerns with them now coming out with issues related to progesterone is that they really didn't take into consideration that most of the studies were not done in Black women. And now, as part of our NMA section of OBGYN, we're looking at this as a factor because we recognize the fact that progesterone may have positive effects in Black women just because of the environment and interaction and so forth and so on, that decreases the risk for recurrence of premature rupture of membranes. And this is a reason that getting a patient back in postpartum and then following her up and having a good pregnancy spacing and getting her on progesterone is really a factor with regard to decreasing the risk. Next slide. So preconceptional risk factors for infant mortality and morbidity, we already talked about obesity is a factor, anemia is a factor, hypertension is a factor, diabetes is a factor, thyroid disease is a factor associated with, quote, neurologic health. And of course, seizure disorders are one of the leading, and the medications related to that are some of the highest risks for developing, having birth defects. And obesity is also associated with birth defects. So next slide. So if you look at just diabetes and birth defects, and we know, for instance, the higher the hemoglobin A1C, the greater the risk for heart defects in infants. I don't need to tell you all that on the phone, but if you look at this, a hemoglobin A1C of greater than 11.2% is associated with a 25% risk of anomalies. And so women who are going into pregnancy diabetic really need to make sure that they optimize their health. And this is certainly what we do very well with women with insulin resistance from PCO. Next slide. And obesity increases the risk for cardiovascular disease in adults and increases the risk for stillbirth, cesareans, birth defects, and so forth. And this is a factor also behind making sure that women try to achieve a healthier weight and don't gain too much weight during their pregnancy. Pregnancy is not the time to really have more excessive weight gain. And we need to really follow the Institute of Medicine guidelines. And what I found even at our own practice when I was at Duke is that people were less likely to talk to a woman who was overweight about how much weight she should gain, because they say, well, she's already gained all this weight anyway, so what does it matter? Well, it matters significantly if you talk about the increased risk of stillbirth, increased risk of cesarean, and the increased risk of birth defects, including neurotube defects. Next slide. And this really just kind of brings it to home. We've talked a lot about elective delivery at 39 weeks. And I would tell you that when you begin to look at the stillbirth rate in Black women, it is significantly higher beginning at 38, 39, and 40 weeks. And so for me, if you're obese and you're Black, this woman needs to be delivered early. She needs to be delivered no later than 39 weeks. She should not go to 40 weeks, 41 weeks. And one of the travesties, in fact, in our infant mortality review is that we had a number of women who were obese, who were diabetic, who didn't be getting delivered on time, and they indeed had adverse pregnancy outcomes, including stillbirths, several of them in that study. Next slide. So preconception of folic acid, I've already told you, it decreases the incidence of spontaneous preterm birth between 28 and 32 weeks. What have I shared with you? Very low birth rate, increased risk of infant death. So have a significant effect. It did not have a significant effect beyond 32 weeks. Again, the idea of a woman being on a vitamin 1 year, 3 months, 4 months at the time of conception is very important. Next slide. And so, again, these are the final factors, as Barbara wanted me to cover, the importance of prematurity and preconceptional health, screenings for medical and social risk factors is the key. Providing appropriate vaccinations is the key. Counseling based on age and race and medical conditions. Health education, why is it important to do these things? Not just it's important to do it. Talking about these type of things and talking about generational health, and ultimately healthy children produce healthy adults. Healthy children, healthy adults. And we used to say in the Healthy Start word, the health of a community is really about the health of its children. The health of a community is about the health of its children. And then my last slide should be coming up. So, generational stress and stresses in Black women from slavery to present are part of the fetal origins of adult disease, whether we're talking about hypertension, whether we're talking about obesity, whether we're talking about diabetes, whether we're talking preterm birth and infant mortality. And then you add to that segregation, economic inequality, inequalities in education, and systemic racism. They all have their impact on overall infant health, and as a result, have an impact on overall adult health. I think that's the last one, Doctor. Is that it?
Yep.
Thank you so much for this excellent top shelf lecture. Dr. Neighbor-Stevens, may I ask him 2 quick questions?
Absolutely.
I have 2 questions. One is, I worked with a group called the Executive Leadership Council, and I found that diabetes, high blood pressure, obesity, and death rates were the same in that group, despite their high economic status. These were gentlemen and ladies who ran Fortune 500 companies. That statistic fit with this childhood or infant mortality. And number 2, how much does the health of the man, of the male, preconception play in the health of the fetus?
Well, I would tell you that it plays a major role because, again, we know that obese men, hypertensive men, first of all, have poor health habits themselves. But theirs is generational as well, because it probably came from the fact that that fetal origins of adult disease is, again, part of them. And so it really does impact fertility, number 1. And then, of course, those are the factors. But the overall health of the baby really is about the nutrition of the mother and how well she is taken care of during the pregnancy. Less so about, now again, fathers pass on genes, and that may be a factor, but birth weight itself and overall pregnancy outcome is really tied to the health of the mother.
And the economic relationship.
The economic relationship is one of the things I want to kind of share with you again, because, we know that if you talk about obesity, hypertension, and diabetes, they are all part of the fetal origin of adult disease. And think about, so being a small for gestational age at birth, being less than 7 pounds, being 6.5 pounds, is associated with you developing a higher risk for developing hypertension and diabetes and obesity in your adult life, regardless of which side of the track you're on. And then you add your childhood nutrition to it, it plays a role. So when we think about adolescent obesity, it is part of the whole cascade. Now, one of the things that we know is that we can counteract a lot of that through breastfeeding. And so, again, when you think about being small for gestational age or being premature, it is so important for the preterm baby to get the mother's milk. Why is it important to get the mother's milk? Because preterm milk actually has different protein content in it than full-term milk. So even if she's getting the milk from a donor, if it's not the same. And so we encourage women who have preterm babies to pump their breasts, to give their babies their milk, because it decreases their risk for not only childhood illnesses, but also obesity, diabetes, and hypertension.
Thank you, Dr. Brown. I think that there are a number of questions that are waiting for you, Dr. Brown. So I hope that you can hang in with us until we get to
Sure.
end.
Again, and I'm trying to turn my computer back on, Barbara, see if I can get some internet. I told you Spectrum, it wipes me out just like that. So, yeah. But fortunately, you got a phone that's not on the same system.
Good, good.
Dr. Neighbor-Stevens and Dr. Brown, if I can just jump in for one moment. Dr. Brown, first of all, thank you very much. Can I just ask kind of a housekeeping question? When we talk about infant mortality, what's the range we're talking about? Because you mentioned preterm deaths can count. How old before we stop saying infant mortality? Is that pre-birth to 1 year? Can you give us
1 year?
Just
Absolutely.
What it is?
It's 1 year. And keep in mind, there are neonatal deaths and post-neonatal deaths. And the pediatricians who are going to talk about those type of things here, in my neonatology colleagues, can address the fact that the first 28 days of life is really the neonatal death period. And this is where most premature babies lose their lives. The 23 to 24 and 25 weekers that we have in Black infants, which is and that's the reason that we have such a higher risk of infant mortality in Black people. And that is that early deaths. And babies are surviving a lot longer and earlier these days, but in reality, those babies under 25 weeks have a significantly higher risk for adverse outcome.
Thank you.
And with that, I think we will segue to Dr. Michael Young. Dr. Young has spent the majority of her career in the DC area at Howard University. She is a world-renowned authority on breastfeeding and lactation. She has served as the head of NICU and newborn services at Howard, as well as interim chair. Her research areas have been all related to that period. And without further ado, I'd like to turn it over to Dr. Michael A. Young.
Hello, how are you doing?
Hello, welcome.
Give me that first slide. Thank you. I'm happy to say that Dr. Brown touched on a number of things that are important in terms of infant mortality. I'm excited. Of course, I know Dr. Brown is a breastfeeding supporter, and that's a wonderful thing, and it's a large impact for us in terms of the health of our babies. Next slide. You can give me my first slide after this one. Thank you. Hello?
We have a little bit of a lag. Why don't you go ahead and start?
Okay.
We'll pick
Well,
up.
the definition for infant mortality is the death of a child, an infant, in the first year of life. So they die before their first birthday. There is a combination of what we call, as Dr. Brown referred to, perinatal deaths for infants who are born 25 weeks and up. There's a higher loss of infants in that first week of life for them. And that does skew our statistics somewhat. There are three leading causes of infant mortality, all of which people of African descent are overrepresented in. But the most significant of those is low birth weight or prematurity. I had some slides that would indicate that, how you see it over the years and how it has been sustaining over the years. Fortunately, Dr. Brown's slide has some of that information on there for you. Very good. Thank you so much. Can you back up just a little bit? You'll notice this is 1997, and you have a cluster around what congenital anomalies, which is what people know as birth defects. And even though pretty much when you talk about congenital anomalies, you're talking about what can happen in a human pregnancy. And so they should be pretty much the same. And these are close, but even here, non-Hispanic Blacks and Native Americans tend to lead with congenital anomalies, with birth defects. And those things, their medications, their genetic defects, they can still, toxins, those things can affect the development of birth defects. Low birth weight, those are babies born weighing less than 2,500 grams or 5 pounds, 8 ounces. Generally not related necessarily to how long they've been in the womb, but that weight is that cutoff for a low birth weight. And here you see, again, African Americans lead the way in that. And then sudden infant death syndrome, both Native Americans and African Americans are overrepresented in that category. Next slide. The more recent look at the leading causes of death kind of flip low birth weight and congenital malformations. We used to have them as close together. Today, with better obstetric care and earlier ability to detect difficulties, and what we've learned in medicine about the medications and some genetic predispositions, we've kind of dropped congenital malformations into the second level, and low birth weight is the one that is leading. We've added maternal complications, which Dr. Brown has talked about as well. Accidents are related to that, but then sudden infant death syndrome becomes still a part of the categories. And if you're looking around across the slide, our African American death rate versus our Hispanic white, non-Hispanic white deaths are there. And we still have our numbers elevated in all of those categories. Next slide. When we look at our low birth weight live births, you'll see over the time, we are still overrepresented. Next slide. What contributes to this low birth weight tendency has been spoken to. This perinatal mortality rate by race that I have here is one showing you that when we have fetal deaths at 28 weeks up to a week, that these, again, in the very tiny babies, African Americans lead that number as well. Next slide. So what are these risk factors for preterm and low birth weight? You can keep clicking to bring the numbers up. At poor prenatal care, inadequate nutrition, smoking, drug and alcohol abuse. The poor prenatal care is a major issue because it doesn't allow the physician to pick up early things that could be prevented. You can have mothers that have a cervical problem, insufficiency, a uterine anomaly, too anemic. All of those components impact the outcomes for babies. The maternal conditions Dr. Brown has spoken about also impact significantly preterm birth. Next slide. Advance. These are the organ systems that are incompletely developed in a term infant. That means a baby born fully, who has spent full time, 40 weeks in the uterus. The central nervous system really doesn't completely develop until your teens, but the quality of the white matter that determines how you function, a lot of it grows in that first 6 months. And it's important. The retina is not developed until a month after delivery. This is in a term infant. The pulmonary alveoli, the systems that you breathe with, are not completely developed until almost 4 years of life. But the structures in those first 6 months is important in their development. The kidneys are immature and they must be able to mature to concentrate your fluids. Yeah, the immune system is present, but it's not developed so that it responds well. It also depends on how long that baby has been in the mother, whether they're getting enough antibodies crossing that placenta to protect them. But most important in the immune system, the antibody, immunoglobulin type A, secretory IgA, is very low normally, and it doesn't really reach adult levels until almost 12 to 18 months. This means this is at term. So our preemies then are even more impacted when they come early. Next slide. And so this little table is just showing you the complications we have in preterm infants by their week of birth. And you can notice in that first column, the 24 to 26 week infant has the most problems with the lungs. That's respiratory distress syndrome, has an increased risk for bleeding in the brain, and therefore challenges in repairing it. The chronic lung disease, if the babies come very immature, and even though we have medicines that can help deal with the lungs, they cannot overcome that growth if it's too early. There's not enough lung tissue, and it takes time for it to repair. And so they have chronic lung disease. NEC stands for necrotizing enterocolitis. That's the immaturity of the newborn's gut. And we see more deaths in babies who have neck, they require surgery, they have a longer length of stay. And it's so important for them to be able to enhance their nutrition. And if they have problems tolerating the feeds, that's going to make them sicker and increase their risk for sepsis. And then general infection, as I said before, the immune system is immature. So 44% in that first column, many of them just generally are unable to protect themselves and mount the kind of immune response that you need. And it decreases, all of those aspects decrease as the infant approaches a term. The 30 to 32 weeker is still not a term infant, but you can see there's a great bit of difference in their risk for all of these complications of prematurity, low birth weight. Next slide. The next leading cause of death is SIDS, sudden infant death syndrome. It is still a leading cause of mortality in the United States. The overall numbers have declined by 50% since 1990, but the numbers in our Black and Indigenous population remain too high. And so reducing the risk for SIDS remains a very important priority. Next slide. And the SIDS, as you can see on this slide, just represents almost 50% of a process we call sudden unexpected infant death. And the other contributors to that, 31% happen with accidental suffocation, 24% with suffocation and strangulation, not safe sleep settings that protect an infant. And then 31% of our sudden unexpected infant deaths are still unknown. But for the area of sudden infant death syndrome, that 45% you see there, we do have things that lead to the risk for that process. Next slide. You can see here when we combine unexpected deaths, all of them overall, they've been falling according to the years. But sudden infant death to a substantial drop when we discovered that positioning the infant was important, as well as some environmental components that contribute to an infant's death. Next slide. Those risk factors. Move forward with the slide. Thank you. It's a male predominance, so our male children are at greater risk. Next. It's more likely to occur if you put the baby on their tummy or on their side. And this is something that we see still an issue. Generationally, a lot of times our grandmothers still want to put the baby on their tummy to go to sleep. And that can risk their respiratory efforts. It's one thing to have a baby on your lap, patting them and they're on their tummy, but when you put them down to sleep in the prone position, that increases their risk for sudden infant death. And especially if the sleeping materials that they're laying on are too soft or too fluffy. Next. Mothers smoking during pregnancy are the babies in the area of environmental sleep, of environmental smoke. So moms will say, well, I'm not smoking around the baby, but they are. If it's in their clothes, it's in their hair. If they're smoking outside, that still puts the infant at risk. And so that area of exposure is a problem for the developing baby inside of mom, as well as the baby once that infant has been born. Next. Overheating, too many blankets, and again, the bedding. Next slide. Waterbeds, sofas, blankets, pillows have no place in the sleeping area for an infant. Inadequate prenatal care, and we say that because there are some things, infections, that can predispose an infant to a sudden infant death syndrome. The peak period of sudden infant death is in that first 6 months. Most are occurring in the first 1 to 2 months. Next. Our young mothers, some of that has to do with their inexperience with handling their infants, but some of it is that inadequate prenatal care also in that age group puts them at risk for missing issues with infection and development. Next slide. Next point. Prematurity or low birth weight, that in itself is a risk for sudden infant death syndrome. We always teach our moms and dads infant resuscitation, because in spite of doing all of these other things, just having been born preterm with an immature respiratory response, those are things that even while waiting for the baby to grow and develop, it still puts them behind other infants born at term. Next. Being born as an African American or American Indian, that in this nation increases their risk for sudden infant death. Next. Not being breastfed and not receiving breast milk substantially increases their risk. Next slide. So is there anything else we could do to decrease Black infant mortality? We talked about good prenatal care. We've talked about looking at development early, improving mother's nutrition. Well, Dr. Brown alluded to it, and I'll talk a little bit more about it. We could breastfeed our babies. Next slide. The way to really look at this is, because I think people know that human milk feeding is the best feeding for a human. But they don't understand the risk of not having been breastfed. So the way to look at this is we look at the excess risk. You can advance to the slide. For a disease process if the baby is not breastfed. So for ear infections, 100%. Keep going. Eczema, 47%. I've highlighted diarrhea and vomiting because that's 178% excess risk for that disease if the baby isn't breastfed. We lose about 1,000 children a year in this country with diarrhea and gastrointestinal infection. Hospitalization for lower respiratory tract disease in the first year of life, 257% risk. So we have children dying of pneumonia, getting spread of the infection along their adenoids and into the brain that puts them at risk. Asthma with a family history, asthma, no family history, both are increased. Childhood obesity, increased. Type 2 diabetes, increased. But these are the things that kill our children. Acute lymphocytic leukemia, 23%. Acute myelogenous leukemia. And then look at this, sudden infant death syndrome, 56% excess risk for that happening to your child if you don't breastfeed. And we're not necessarily talking about a long-term. Ideally, pediatricians would like babies to breastfeed, for mommies and babies to have breastfeeding exclusive human milk for the first 6 months. But as mentioned by Dr. Brown and what we found in our work, even 4 months, even combination feeding with breast milk, getting at least 50% of the milk as breast milk will make a difference in all of these. For term infants, preterm infants, that necrotizing enterocolitis I spoke about before, that's where you have, it's like sores coming into the GI tract all the way down. We see that in infants, 138% excess risk for that if they're fed formula. And the American Academy of Pediatrics has make a stand at that, particularly as it relates to preterm infants, infants born weighing less than 3 pounds, 3 ounces, that's 1,500 grams, definitely infants less than 2.5 pounds must get their mother's milk. That is the requirement from the Academy since 2012. Exclusive human milk and exclusive human milk fortifiers for the preterm infants. And if mothers don't want to give their own milk, then we can use bank breast milk. It's not as specific as the milk of that baby's own mother, but it still decreases their risk for necrotizing enterocolitis. There are benefits for the mother as well. Protection from breast cancer and epithelial ovarian cancer. Next slide. Keep going. So we can, mothers that breastfeed can decrease the risk of high blood pressure in them. Keep going. Type 2 diabetes, ovarian cancer, breast cancer. And in this breast cancer piece, Black women have a particularly aggressive type of breast cancer called triple negative breast cancer. When mothers breastfeed, women who breastfeed and get breast cancer are over 70% less likely to get the triple negative type when they breastfeed. And if they do get cancer, they're more likely to get a type that is more responsive to chemotherapy and treatment, and they're much less likely to have subsequent cancer and death. Next slide. The current breastfeeding rates are improving, but not enough. We have not met the Health 2020 goals. They've already set up the 2030 goals for the next 10 years, and we've got some work to do. Actually, our Hispanic brothers and sisters, they continue to, as you see time go on in terms of duration, as we are looking past these 2020 goals, they stand to continue with duration better than even our white colleagues in particular. Many of them, they'll come into this country and start adapting our bad habits in the United States. The United States is not particularly doing the best job for breastfeeding when you compare us with other developed nations. Next slide. When we look at the data, we say increased breastfeeding among Black women could decrease our infant mortality rate by as much as 50%. Yes, we may come with small babies, but if we feed them human milk, they work out better. Even our term infants have less disease if they get breastfed. And then they certainly have less risk for sudden infant death if they are breastfed. So we have a job to do in that regard. Next slide. Breastfeeding is species specific. You'll never see a cat or a dog come to you with a cup asking you for milk to grow their babies. We need to feed our babies our milk, human milk. It's a continual immunological update between the environment and the infant. So whatever mother's environment is, she's making antibodies, she's doing things in her immune system to help protect that infant and provide that immunoglobulin that protects them particularly. In this COVID status that we just are coming through, the mother makes antibodies if she gets that disease and it's in the breast milk, it's moving faster. The antibodies are that protect the newborn. It's moving faster than anything that we have to give them. Because, we can't give vaccines yet for COVID to children who are less than a year, 2 years. Are working on vaccines for that be under 6 year time frame, but for all types of things, including the flu. And when we talk about those viruses, babies under 6 months are not getting flu vaccine. So we put flu in the same category with coronavirus. And there's no vaccine for babies in that time frame. So you want to be able to give them that milk from that mother who's either been vaccinated or who's been exposed. Breastfeeding is a single intervention that confers a lifetime of health benefits in infancy and beyond. Next slide. So we want, advance the slide, we want families to know that affordable and attainable healthcare begins with being breastfed. And deciding to breastfeed a baby to help protect them from infant mortality is not just a choice, it is a healthcare decision. And that's how we need to approach it. Give our mothers and families all of the information and support that we can to help work on the lives and contribute to optimal lives for our infants. Thank you. I'll take your questions.
Thank you so much, Dr. Young. Dr. Maxey, did you have a question?
Yes, it's sort of self-serving. Why do male infants have a higher death rate than females? As adults, we die earlier than females. We're catching the bad end of the stick at both ends.
Mm-hmm. Well, I could just tell you you're the weaker sex, but I think you all would have a problem with that answer. We don't know. Maybe that other X or having a Y puts them in a little bit of a challenging position. There are more male babies born. Why more? And maybe that's also a process because we're going to lose some. But it's something that makes the male a little more vulnerable than the female. And I don't have a real answer for that one, that other than we're the default species. If there's no Y, there will be a female born. So you have
I saw Dr. Brown
But
put his
an
hand up to
XO.
defend us on Father's Day.
That is actually a great question. You know that first of all, that males mature in utero at a slower rate, and so when you think about preterm male infants, they are much more vulnerable to certain to their prematurity. Whether you talk about necrotizing enterocolitis or whether you talk about respiratory distress syndrome, and so that is one of the factors that plays a role. Why do they mature a lot slower from a respiratory perspective is basically just part of that Y chromosome. And Dr. Young is absolutely right. We all start out as females in the embryologic process, and then there are certain things that the testes secrete that make us become males. And so the reality is that we are weaker at birth, and we certainly are weaker if we're born preterm, which is a real factor related to our respiratory development and our susceptibility.
Yeah.
You can
But we still need you. We still need you.
We catch up.
There's a few more questions in the chat room. Are we ready to address those?
Dr. Young, if we certainly catch up if we're breastfed.
Yes.
Let's just take one, Michelle, so that we can bring on Dr. Bean, and then we can address a lot of questions. I have a sense that there's pent up questions.
Okay, here's an interesting one. Any studies correlating SIDS and gas stove ownership among Black families?
I haven't seen it. I have not seen anything that correlates that, but I haven't really looked in the area of environment in that degree.
That is an environmental study per se. Okay, thank you. All right, I'll hold the other pent up questions till I get the green light from Dr. Neighbor-Stevens.
Oh, thank you, Michelle. So I am just so pleased to again be able to present one of my fellow colleagues in the vineyard of pediatrics. Our next speaker is the Dr. Exelina Bean, who is a fellow Tennessean of mine, but who has had the opportunity to train undergraduate and professionally on the East Coast, and then migrate to the West Coast, where she has her own fan base, having spent a number of years at the Martin Luther King Center, and now at Meharry back in Nashville as the chair of the Department of Pediatrics. I couldn't think of a better person to round out this trio approach to how we can save our babies other than Dr. Bean. With that, turn it over to Dr. Bean.
Thank you very much. It's interesting because a lot of what I was going to say has already been said, which means that I get the opportunity to just add some contributions to my colleagues who have already covered most of the most important information that we're talking about. I will start out by saying, for example, thank you, Dr. Brown, for giving a shout out to Dr. Ezra Davidson, who, by the way, was at King when I was there as a resident, and who was chair of the Department of OBGYN at that particular time. And I also like the fact that we have keep referring Dr. Walks to the, no, that wasn't Dr. Walks, to the Healthy Starts program. For those of you who do not know what Healthy Starts is, some over 25, 30 years ago, the decision was made at the federal level to try to address the issues related to decreasing infant mortality. And they set up a number of programs, which they called Healthy Starts, which have been trying to address this problem over the last 30-something years. And there are Healthy Starts programs in almost every state at this particular point, and most cities. In Los Angeles, For example, I work with the Healthy Starts program, which targeted at Shields for Families, which I helped to start, which targeted perinatal substance abuse issues and the problems associated with that, which is a major contributor to many of the problems we see in terms of infant mortality. And in Nashville, we have a Healthy Starts program, which has just started, which is also trying to impact infant mortality. So wherever you are, there's probably a Healthy Start program in your city. For those of you in the audience, in which it would be really important for you, if you're interested in this topic, to reach out to your Healthy Starts program. What they did was establish models which have shown to be a benefit to trying to reduce the incidence of infant mortality. And as you pointed out, infant mortality covers the whole period from birth all the way, and includes, by the way, sort of as a stepchild or included, is that concept of infants who died during the perinatal period. So, but the definition actually refers to live births. So it's live births up to right before their first birthday. So 364 days of your life, you're under infant mortality. And we actually do it in terms of the number of deaths per live births. And that was covered extremely well by my colleague, Dr. Young, and also the previous speaker, Dr. Brown. The models that were developed, which were shown to be effective in working with this population, should not surprise you. They were all models that looked at providing support to families. So we were talking primarily about case management support, all the way up to comprehensive centers and if I remember correctly, Dr. Young, didn't you run one of those kind of centers, which was trying to provide comprehensive care to this population? So that what I'm going to do is, and I know that it's extremely important that we leave time at the end for question, is that I'm going to try not to be redundant. Now that can be difficult, considering that there's many of the things that you have heard are all very similar and very basic. So I will try, and I don't have slides, which helps considerably. So that way, since most of what I was, that most important numbers, statistics, and things have been covered extremely well, I'm going to stick to trying to add something to some of the things that were said and talk about it in the context of what happens when these children go home. So we've talked a lot about what happens when that preconceptually, what happens during the pregnancy, what happens when they're first born. And then we have to talk about what happens for the rest of their life. Remember, neonatal period is the first 28 days of life. And a lot of the things that we have talked about so far are related directly to that period. So I'm going to talk about it in the context of some of the same things we've already said, but try to expand upon them. So for example, you've already been told that the main causes of death related to infant mortality are your birth defects, your preterm births, and maternal complications of pregnancy, which we'll come back to a little bit later, sudden infant death syndrome, and injuries, or accidental or unintentional injuries. And by the way, since nobody's talking any much about that, I'm going to spend some time specifically on that topic. Under birth defects, I will remind you that a lot of the issues related to birth defects is the biggest issue is probably the continued disparities. As was pointed out, we have done a lot of work in terms of decreasing the incidence of birth defects, but there's still the lingering disparities in terms of why is it that African Americans still have a disproportionate amount of birth defects in terms of not profiting as much from the interventions that have occurred, which has decreased the birth defects on every population. And we still have not seen that benefit. We've seen the benefit, but not at the same rate as everybody else. So we still have a birth defects rate that is 30% higher than any other population. Now, interestingly enough, the incidence of birth defects is not highest among African Americans. the incidence of birth defects is actually higher. For example, I think that was mentioned already, that you see an incidence of birth defects is actually higher among Native Americans and even Hispanics. But what has happened is that many of the interventions that we have shown to be effective, African Americans have not taken advantage of them at the same level as other racial groups. And that's something we really need to ask questions about and look internally, or look at our population and our people and ask the question, why? So one of the things that was mentioned, for example, was the simple intervention. One of the major birth defects are those which involve the brain, anencephaly, meningomyelocele, those kind of defects. And the simple intervention of taking a vitamin a day, once a day, prior to getting pregnant. But African-American women have the lowest incidence of actually just simply taking a vitamin a day. The other one is the issue of planning pregnancies and of getting preconceptual care. And when you get preconceptual care, they tell you, you go to see someone, they say to you, you are obese, you are at risk for developing diabetes during pregnancy, you are hypertensive, you are at risk for developing preeclampsia and hypertensive disease during pregnancy, you are at risk because of your nutritional status. And then they tell you, we need to do these things for you in terms of making sure we decrease those risks prior to you becoming pregnant. And one of the most important things is the issue of getting good prenatal care and introduction into prenatal care as early as possible during pregnancy. At which point, for example, birth defects, they would put you on supplemental folate in addition to that vitamin a day that you had been taking. They would begin to address the issue of you at risk for diabetes. And diabetes during pregnancy is one of the highest risk and association with birth defects. So we can begin very early to identify and to treat that risk so that we can decrease the incidence of birth defects. Unfortunately, the important thing is that birth defects occur early in pregnancy. And therefore, it becomes extraordinarily important to get into prenatal care and to get intervention in the first trimester. And most of our population, if we are lucky, show up in the second trimester. And then we're talking about many of them showing up in the third trimester and having no prenatal care. And a lot of the risky behavior that has already occurred has resulted in poor birth outcomes. One of the questions that was asked in the chat, I noticed, and which we do not understand that either, but you asked the question of whether or not stress could be genetically explained, could influence your genetics, and whether that could influence outcome. And the answer is yes. And we don't know all of the things that result in that, but we do know that there's a concept now called epigenetics. And so I encourage you to look up epigenetics because that's well beyond the scope of this discussion. But yes, things such as stress, things such as environmental influence impact how your genes are expressed. And what's interesting is that once that has occurred, once that exposure to an adverse environment, once that change has occurred, it is inheritable. So whether or not that is why there is such a problem with things such as the increased incidence of prematurity, which is continued in our population, is not, nobody is very clear on that one. But yes, the role of stress can be genetically expressed in your actual genes. Now, stress is an extremely important component of the outcome of pregnancy. That's already been mentioned. And so it's something that we need as well to address. And it's something we'll talk about a little bit later when we talk a little about injuries and trauma to children after they go home. We talked about preterm births and low birth weight. And I was neonatologist as Dr. Michael, Dr. Young. And I took care of children in what I call the high-risk follow-up program in South LA after they were born, after they were discharged up until they basically became adults, 21, 22 years of age. So I saw the aftermath. And one of the problems is that the majority of these children who are preterm, it is absolutely true. A lot of what happens to them are what results in the death, and they make up a disproportionate component of the actual infant mortality rate that 1 month. So if we could eliminate prematurity, we could eliminate a lot of the dying that occurs in these children. But once they are discharged from the hospital, they are a very high-risk population. They often have ongoing neurologic problems, and they often have, as was pointed out already, they have lung problems. The lungs are still could be immature. And so they die after they're discharged primarily from respiratory problems. So what does that mean for our population? It means that environment is extremely important. And it means that if you already have lungs that are damaged, putting children in environments in which those lungs can be further damaged results in them having increased risk for getting problems that ultimately, infection being the most common, that ultimately results in them dying respiratory deaths later. What are those risk factors? They've already been mentioned. And smoking is probably one of the most important ones. When you ask the question of whether or not gas stoves make any difference, what we say is that poverty makes a difference. Interestingly enough, if you look at infant mortality, the highest death rate occurs, it can be related very specifically to 2 issues: maternal education and poverty. Maternal education is, to some extent, we don't know exactly all of the reasons, but we assume it's because it influences almost everything that occurs or happens to that child in the next year of life, whether they get to see, whether they are taken regularly to see the doctor, whether or not you appropriately respond to trauma, meaning if I fall down, whether you appropriately respond when the child gets a fever, whether you appropriately utilize the healthcare system, whether you appropriately support your child's development. All of those things are influenced by maternal education. The other one, of course, is poverty. Where you live makes a difference. And as you know, you can specifically track and link deaths to census tracts. And it isn't accidental. So yes, we can do it by race, but race often becomes a substitute or for actual poverty. So in environments in which there is poverty, you are likely to have a much higher exposure to toxins that are likely to result in adverse outcomes. So if the kid has bad lungs and they are in an environment in which there are cockroaches, in which are likely to result in them having increased risk for having asthma, bronchospasm, et cetera. If you have environments in which they are exposed to more toxins, such as it's very common practice, for example, they've looked at where we can talk about lead exposure, which you all are aware of in terms of environmental lead. We all know that you can see it in old buildings with paint. You can also see not necessarily gas stoves, but we know the heat in many of the buildings that we're talking about is inadequate. So environmental exposures are obviously going to go up when you have poverty. And so those are factors which influence whether the child survives the next year of life, even after Dr. Young and myself have done a whole lot of work in trying to keep you alive long enough to get out of the nursery. And then we put you into the real world, in which very often our children are not valued, are not cared for, and do not get the appropriate support that they need. Now, we talked a little about the complications of pregnancy, so we're not going to spend any more time on that, except to mention, and I'm surprised it hasn't been brought up already, of course, is the increased incidence and maternal mortality. among African-American women, which has now become a big issue, in which maternal mortality among African-American women has increased by double in the last few years. And I know that Dr. Stevens was involved in that when she was in Nashville, and may want to speak a little bit about that later on. We also we talked a lot about sudden infant death syndrome, and we talked about the fact that African-American women have the highest, children have the highest incident of sudden infant death syndrome. Want to point out that the simple process of putting your child on its back, we used to call that back to sleep, that process, the group that was the most resistant to doing that were African Americans. And the people that they usually blamed was their mama. So the grandmother who would be the one who was the least supportive of the mother being willing to put their kid on their back. But it's been a issue of well documented that putting them on their back makes a difference. Now we are getting to make headway in terms of SIDS, but again, we have the usual disparities. We have seen a significant decrease in the amount of SIDS, such as we have now split the causes of infant mortality, which Dr. Young showed you, so that sudden infant death syndrome is now number 5, as opposed to number 4 cause of death in children in the first year of life. But even with that, the disparities stay the same. We still have a major disparity. All racial groups have decreased, but African Americans have decreased the least. The next thing was the recognition that SIDS was also related, and we talked a little, I think it was mentioned already, but I'll remind you all that one of the things we do now is called safe sleep. And the reason why is because after looking at what happened to children who died, even when they were on their back, what they discovered was that those children often were victims of strangulation, suffocation. What are the 2 major components? Again, some people call it culture. And we all believe that culture should be supported, and we all believe that we should respect it. But for example, routine co-sleeping or sleeping in the same bed with your parents, that's culturally very appropriate in many cultures, especially among African Americans. However, it is noted to be, or has been documented to be, an increased cause of death because of suffocation. So now we really asked you, get a bed, get a crib, push it next to your bed. Make sure it's there because you want to continue to breastfeed. But it also is safe. I know you love those animals and all of those other things, and we spent so much money on trying to decorate them cribs, but those are no longer considered to be safe because children get strangled in them, they get caught up in the bedclothes, etc. So those are the kind of cultural issues, which we call culture, which need to be addressed in terms of trying to decrease the incidence of death among our children. Now, the other issue, which Dr. Young spent a great deal of time talking about, and I will not therefore do anything other than to again promote the concept of breastfeeding. The highest incidence of breastfeeding in this country is if you are white, educated, and middle class. The lowest incidence of breastfeeding in this country is if you are Black and poor. Okay? So that tells you something in and of itself. But I really cannot emphasize as strongly as Dr. Young has already done the importance of breastfeeding. Now, the other thing we want to talk about is injuries or accidental, so-called unintentional or accidental injuries. What are unintentional or accidental injuries? Well, one of them is the issue of, as we pointed out, babies who die because of suffocation. We used to, it's in the Bible, in which all of you have probably heard the story, but in terms of actually laying over on a baby, which is another one of the reasons why we very much emphasize don't do it and avoid it. A big contributor probably to that, whether we like it or not, is the increased incidence of obesity among our population. African Americans, women especially, have the highest incidence of obesity, followed very closely by Hispanics. But those obviously represent a risk factor that we can't avoid. And anything we can do to avoid having putting our children at risk, we should try to do in order to be able to do that. Now, I'm going to spend a little bit of time talking about some of the other injuries or accidental injuries that we talk about. Domestic violence. One of the major traumas that we have for pregnant women, and then subsequently our parenting women, especially those who at this point are at the highest risk. And those are usually women without significant support system. The African-American community has always depended upon its extended family system. And at this point, especially in many urban areas, but also even in rural areas, there's much less in the way of extended family. So that you often have the so-called nuclear family, which was not a cultural thing. And that nuclear family, unfortunately, in a large percentage of the time, consists of the mother and the baby, and the father, who should hopefully be involved. But one of our problems is the issue of domestic violence. Children get caught in the middle of domestic violence. As you know, domestic violence is a major contributor to poor outcome during pregnancy. But after the baby is born, the domestic violence doesn't go away. And even though we have an increased risk for child abuse, which I'll talk a little bit about later, the big problem is that children are often inadvertent victims of domestic violence. They are there. They are there when the violence occurs. That can actually impact them for the rest of their lives. Social determinants of health, which is not a subject we're supposed to be talking about at this point, but begins to imprint on our children at very early ages as they're exposed to that. But I also want to point out one of the biggest problem is that as the domestic violence occurs, the children are often the victim in this case. Inadvertent victim, accidental. The other one is another thing which people tend to try to refer to as cultural, not putting your child in a car seat. And at this point, it's hard to believe that we still have people who refuse to use car seats for their children. It's the law in almost every state. But the disproportionate number of our population either don't put the kid in the car seat or take the kid out of the car seat too early, or use car seats which are not appropriate for the child, either in size or structure, and are not put in the car seat correctly. Please take advantage of the fact that almost every place has a place you can take your car seat, and make sure that it's in your car correctly and that you bought the right car seat. Okay, so it's extremely important. We also often seem to think it's appropriate to take children to inappropriate settings. And so we decide that it is appropriate to take your baby with you when you go to the rap concert. I'm not joking. I mean, you sit there, you can't imagine it. You're sitting there and you can't believe that these people just arrived with a baby. And so they put them at risk by putting them in environments in which children do not belong. So please pay attention. When we say environments, we're not just talking about what I said in terms of people having to bring in toxins. They don't have to poison your water. For you to decide, for example, not to use tap water with fluoride in it, or not to give your kid vitamins with fluoride. We make decisions which actually, some of it may be educational, but other times we just use this as an excuse. I won't even go. One of the questions that was asked had to do with the COVID-19. Aren't you happy to know that COVID-19 so far has not had the same effect upon children it has on adults, even though the new variant they're saying does appear to be particularly toxic to adolescents. But it was pointed out already that vaccines for the mother are extremely important. So one of the things they also get with prenatal care is vaccines that help to protect the babies in terms of their immune system. We already mentioned that you also get immune from breast milk as well. See how we keep pushing this breast milk. But specifically vaccines, which have the COVID-19 vaccine is safe in pregnant women and probably has some protective effect on babies. They've looked at babies who have gotten COVID-19 and they have done well, which is great. Okay, so but that's not an excuse for the fact that our people are not getting the vaccine. I found that extraordinarily interesting that we have chosen to do that. Influenza vaccine is also extremely important to do. Again, we protect the baby because the baby cannot get the vaccine. And we have not talked about pertussis, but that's another disease in which we said it was eradicated, but it's not eradicated. You got a preterm baby with a bad immune system, then you expose them to these things, then you increase the likelihood of they're going to die. Now, I have not we talked about smoking, and it needless to say, by now everybody should know that smoking is a bad thing to do for babies. Drugs and alcohol. Of the drugs we're talking about, most of the drugs, and we've mentioned the fact that some of these drugs can result in birth defects. So that's why it's so important you get prenatal care and you make sure your doctor knows every single drug you're on. Illegal drugs, most of the time it's not birth defects with the exception of alcohol. And of course, fetal alcohol syndrome is something we see in babies. And unfortunately, it's higher incidence of fetal alcohol syndrome among African-American women than it is on other populations. And I know that I'm taking more time than I had planned to take because I want to make sure we have time for people to ask questions. And so I'm going to spend just a minute talking about the issue of so-called accidental or intentional injury to children. Child abuse. Child abuse incidence has gone way up in the last year. They attribute part of it to the fact that people can't do nothing else but sit at home and try to interact with their children, and nobody's going to school. So at this particular point, the incidence of child abuse has gone up generally. But specifically, if you want to ask the question about African Americans, why is the incidence of child abuse disproportionately high? Part of it is that child abuse impacts every racial group. However, the African Americans are more likely to find themselves involved in the legal system. Part of that is related to poverty. Part of it is related to the lack of support system. It also is to the disparities with which we tend to respond whenever African Americans get involved in the legal system. We all know, even us middle-class folks, we try really, really, really hard to stay away from the legal system. I'm one of those folks, I know me, I'm a doctor, right? And the first thing I'm gonna do is say, I'm a doctor. They ask me, what's your name? I'm gonna put doctor in front of it, okay? In fact, I drive around with a white coat on half the time, just hoping that will decrease the likelihood of my being stopped. We all know that, okay? So, but being poor, or even being accused of crime, as you know, disproportionately puts you into the legal system. So the incidence of child abuse, when you look at the statistics, says that child abuse is much higher among African Americans. It is much more likely to be reported and is much more likely to result in the legal system. And we will not discuss all of the issues related to our children wounding up in foster care. I will point out the only reason for bringing it up is a reality that has to be faced, and in fact, it impacts our children disproportionately, and children under the age of 2 are more likely to be abused and or killed than children of any other age. So we're talking abuse and neglect, and a neglect is more likely to be associated with other problems such as substance abuse. On the other hand, physical abuse is more likely to be associated with the excessive use of alcohol, which, as you know, is also a major problem in our community. So those are community issues which need to be addressed which we have not effectively addressed. And there are programs, lots of good programs around. But they are things that we as a community are going to have to ultimately come up with a solution for, because the solution that has been decided for us is that other people can take care of our children better than we can. And that the best thing we can do is to put them with other people who will take care of them. So that's the solution which I would hope our community does not accept as the only solution for these problems. So I will end at this particular point. And I hope I've contributed somewhat to the discussion, which, by the way, my colleagues have so far done an excellent job of giving you all of the facts. So I got to talk about those things I thought were important. Thank you very much.
Dr.
Thank
Bean,
you, Dr. Dean.
Thank you, Dr. Bean. You still are one of my greatest heroes. And the part that you talked about when I did my pediatric rotation was the percentage of neonates and younger children that had been battered, bones broken and beat up. I couldn't understand that. That really upset me. But Dr. Neighbor-Stevens, would you go with our questions?
Yes, I want to actually bring all of our panelists in on this. And I also want to include my co-moderator, Dr. Walks, because I think all of us have been concerned about the question of the role of stress and how it impacts our whole community, whether we're talking about babies or whether we're talking about marriages, or if we're just talking about individuals. We as a people are struggling with stress. So not just talking about the stress, but I would like to ask all of our panelists to chime in on solutions to dealing with the stress that we can reasonably effect now. You know, sure, it would be great to eradicate all of the social issues, and then maybe one day we will. But what can we do right now to help ourselves? You want to start, Dr. Walks? And then everybody else jump in?
Well, Dr. Neighbor-Stevens, you know I'm very shy and I hate to speak up, but let me start with this. I think one of the things that we've seen today done so beautifully by our panelists is something that the Black Health Trust does over weeks and weeks, is that we integrate the different parts of healthcare. Yes, we may go to a residency in psychiatry or pediatrics or nephrology or something else, but our patients come as one person with all of these things. And so I'm an advocate for normalizing what we as doctors do in talking with each other and helping patients understand, the people that we work with in our community understand that it isn't just one type of doctor that's going to solve all of the problems. For example, if we can normalize mental health care and support as a part of what we do when someone comes in for hopefully prenatal care and very early prenatal care, and maybe connect them or ask them what sort of mental health resources are in your community, we doctors can begin that integration of healthcare. One of the most important things I did as a state health officer was to put in place a home visitation program where we had public health nurses going to the home of every child born in Washington, DC, that came home to a home in Washington, DC. We dropped the infant mortality rate by 20% over 1 year by having folks see what those environments look like and supporting people by normalizing having someone coming to the home. There's something about us meeting our patients where they are as physicians that we can start to do right away. And the first step, what we see here, knowing our colleagues, knowing what they're doing, and normalizing the important work that each one of us does.
Thank you, Dr. Walks.
I couldn't agree more, Dr. Walks. And I would tell you that we talk about resilient strategies that we, particularly during the prenatal care period, which is really a very stressful period of time itself. But I talk about generational stress because the generational stress really is the whole adult origin of disease, the in utero environment and the change in the environment. And we've heard a lot about epigenetics. So how we respond to our stress is very, very different, whether we're talking about having cardiovascular disease. And we know that adult disease that's related to pregnancy complications, including prematurity, including heart disease, are factors that are there. We're still talking about inflammatory responses and how we respond to our stress. And so my objective, even with the pre-med students today, is to try to teach them a little bit about resilience strategies. If you have resilient strategies, then you can teach your patients about resilient strategies. And also treating people like you want to be treated. You know, nothing drives me more crazy in my clinic than to have someone say to the patient, she's late, do you still want to see her?
Mhm.
Well, I'm gonna still be here until 5:30, 6 o'clock doing these epic charts. So of course I want to see her, because they don't know whether she's had to take 2 buses. They don't know whether she's had a childcare issue. They don't know anything about the fact that, other than the fact that she's 15 to 20 minutes late. And she may have come all the way to see me from someplace, you know, for a pregnancy complication or whatever. So, and I had to teach my residents that too. Don't further stress the patient. Don't further stress them. Let's
Amen.
decrease their risk of stress when they get here.
Amen.
One of the things that we are doing, and by the way, it's when I say we're doing it, as I said, we have a Healthy Starts grant. We just started. And there was a previous Healthy Starts grant in Nashville before. We'll talk about that. But we have a new Healthy Start grant in conjunction with the Public Health Department has it, Davidson County. But Meharry is providing the clinical component in OBGYN pediatric. Centering pregnancy is a concept which has been shown to be beneficial in working with this population. And the model that we use came out of actually Memphis. And I know that centering is probably a model that is being used nationwide as well, in terms of doing this group type of pregnancy or prenatal care that allows the mothers to become more support for each other, hopefully, and also helps to address one of the problems, which also is a mental health problem. Somebody mentioned postpartum depression, et cetera. One of the contributing factors is this isolation, and many of our patients are isolated. And so centering allows them to develop a cohort of friends, common, other pregnant women that they have in common. The same thing. We're pregnant. We have many of the same issues, and hopefully they develop a support system that is not just going to be during pregnancy, but hopefully that will go beyond pregnancy. It also allows us to decrease stress, so to speak. So we try to have them all come in at the same time, get their education, all of this. But I think the centering is going to be important. They want us to do something around centering for pediatric care. I ain't figured that one out yet, but I'll work on it. Because right now, so that one I'll have to work on. But centering approach to pregnancy, I think delivery of prenatal care has turned out to be one that I think has been shown to be a successful model for addressing some of these issues related. And probably its main impact is upon decreasing the stress by providing a much more support system that many of these women don't already have.
I'd like to add again, part of that is, again, the fathers are very important. When I talk about the New Fathers Boot Camp and giving the fathers a charge, that you are going to become a parent. This is what this really means to you. This is and keeping them engaged. And I said, I'm not having you here in this class to teach you how to change a pamper, because that's not something that you need to, anybody can do that. The idea is for you to appreciate, the value of being part of this support system. And then one of the grants that we just got here here with the Merck for Mothers program for the Community Care Initiative is the postpartum doula component, to get to the point that Dr. Bean is talking about. We don't need a doula as much for the birth as we do for who's going to follow the person when she goes home, who's going to really be there when she's having breastfeeding challenges, who's going to be there when she's lonely, who's going to be there to pick up the fact that she's having anxiety or stress about trying to figure out how to take care of a child? Now, everybody's in the delivery room, but nobody's around 2 weeks later. And I think that that's really the thing that really is support for the mother, also support for the child, and all those type of things are very important to us decreasing, infant health, but also improving mother's health.
Dr. Young, would you like to add your perspective?
We need to unmute Dr. Young. There we go.
I guess, I don't know if this is the experience in other parts of the country, but I don't think the health education that young people are getting in their schools is positive at all these days. The number of young women that I run into that have like zero knowledge of their bodies, I mean, literally how things work, is surprising to me. And so they come unknown to themselves. So it's very difficult to imagine that they're going to handle another human being in an effective way without some serious support. I think we could do a better job of basic education in terms of health systems, health education. And so that doesn't make the patient and the family so dependent on the basic observations, how to take a temperature, when fevers, the basic care of a cold, when things might be getting worse. Those are things that seem to have been taught somewhere when I was in high school, and you had an idea. And it's not just because I was interested in science. People just kind of knew you needed to have some basic things in your home and things to look at. And it doesn't seem like the public school system has taken on that aspect of general health education to young people, so that they always are feeling inadequate, and that adds to their stress substantially. If they're not understanding you, they're embarrassed to say it. We may not pick up that that adolescent or young adult attitude is really more protective of not having the knowledge, as being dismissive of you. And so we have some work to do there, I think.
I want to point out that I happened to see Dr. Jesse Sherrod's right there, who has apparently joined us. I don't know how many of you know Dr. Sherrod, but I see that she specifically is there. Was that because you wanted to say something?
Dr. Sherrod is one of our founders and has been here since day one. So
thank you. I'm beaming with joy because I feel like equity has been brought to the Black Health Trust by the pediatricians and the OBGYN. Thank you so much. You all were outstanding. And thank you, Dr. Stevens. I know you had a lot to do with this. But my question is concerning, let me just say this too, because I kind of missed the question when they were talking about that Dr. Maxey asked about whether males are the weaker sex or something like that. And of course, you know that intelligence, it's been shown that intelligence is carried on the X chromosome, and we just happen to have two.
Well, I don't know, Jesse, I don't know about Turners and Kleinfelters, but somewhere there's some extra wires along. So, Dr. Stevens, I thank you for bringing such an excellent panel. We learned a lot.
One question concerning the role of the church. I think support systems, and everybody has talked about that, but I'm kind of wondering about the diminishing role of the church in the Black community, and also the diminishing role of mental health accessibility in this country has been a major factor. And I was wondering if anybody is looking at how we can utilize the church to improve health and sex education
and develop a support system. We know that in California, doulas are now, I think they passed the law for them to be reimbursed for their services, I believe. I know it was at one time being considered. But, and that I think is very, very important, because the point was made by Dr. Brown, you know, all the help is there at the delivery, but then when the patient gets home, the grandmother is not there anymore, who was the doula, you know, back in the day. So what systems can we revitalize to support our women as they, you know, give birth and have these kids?
Let me try that one, because I can tell you, Dr. Sherrod, you brought up a very important point. So when we got our first Healthy Start grant in Indianapolis, one of the things, we had this high Black infant mortality rate, and we convened a group called the Concerned Clergy. We made them aware of the fact. And no one, I said, do you really want to live in a city where you have one of the highest Black infant mortality rates? And so we did a Saturday morning breakfast with the Concerned Clergy. They got behind these initiatives that we were talking about, including establishing health clinics in the communities. I can't tell you how many health fairs I did at the church.
Right.
I would tell you, and these were like, I was an OBGYN, I'm doing health fairs, delivering to women. I said, you know, on this Saturday, we talking about everything. There's nothing off the table. There's nothing off the table for us to talk about in terms of your health and the reproductive health and the health that you're trying to bring into the world. And I think that they can play a role, and I think they've kind of gotten shy about it. But the reality is, in order to talk about it, we had to also talk about education on, you know, sexual activity and, you know, there's risk factors. And, you know, we know that they know. And so doing it in the church, having those sessions in the church actually seemed to make them a little bit more palatable. You know, to everybody, even in the community. So I would applaud you for bringing that back. I still think it's a very critical role that they can play in the community.
And I think that is something we need to bring up again on one of our sessions. I want to congratulate Dr. Barbara Neighbor-Stevens for bringing this panel of Dr. Young, Dr. Bean, and Dr. Haywood Brown. This has been excellent. I took about 3 or 4 pages of notes and stuff. And so that's something very, very important. I want to remind everybody that we have a program next week on the 25th. We've co-ventured with State University of New York, a Downstate Medical Center, to provide the first international symposium on long haul syndrome. And everyone is invited. For physicians, I believe we have CME credits, but we expect it to be a very, very good program. That's on Friday, the 25th. I think we have a flyer. The first international symposium on long haul syndrome, which is getting to be of great concern. We also know that our theme has been common sense, that we know there are the Delta variants and other variants that are still causing great havoc, and they still are more infective, and they may or may not be adequately covered by the current vaccines. That remains to be seen. So I thank our guests, and we do have a usual way we close out with Ms. Brenda Lieger and Pastor Pointer. And Dr. Stevens, Dr. Walks, are there any further items we need to deal with? We're at the top of the hour on Father's Day, and I'd like to wish a happy Father's Day to all the fathers on the phone.
Happy Father's Day, everybody.
Happy Father's Day, everybody.
Dr. Brenda Lieger, and then Pastor Pointer.
It's been wonderful for the doctors. Thank you guys so much. I look forward to this all the time. Happy Father's Day. Must have been cold there in my shadow to never have sunlight on your face. You were content to let me shine. You always walked one step behind. Did you ever know that you're my hero? You're everything I would like to be. I can fly higher than an eagle. With you as the wind beneath my wings. I can fly, you let me fly. God bless you.
Praise God, Sister Yeager. It's a blessing. Let us look to the Lord to receive his blessing. O God of the most holy name, lover of all nations, we thank you for your servants, Dr. Exelina D. Bean, Dr. Michael A. Young, and Dr. Haywood Brown. We thank you for all that they have poured into us on this day. We pray, O Lord, for peace in our hearts, in our homes, in our nation, in our world. The peace of your will, the peace of our need. In Jesus' name, amen. Thank you, family. It was wonderful again today.
Absolutely.
Outstanding.
Happy
Outstanding.
Father's Day.
So much.
Happy Father's Day
Thank you,
to all.
everybody.
Healthy
Peace and blessings.
Love you.
See you next week.
Bye.
Thank you, Michelle and Simon and Yakini.
Hey, Jessica.
You're welcome.